Okay, we're going to do some dermatology here for 30 minutes. All right, how many of you have seen a rash you don't know what it is? That should be every single hand, right? Join the club. Me too. Me too. The good news is that we're going to see a lot of rashes, and honestly, most of them we're not going to know what it is. Dermatology is, a multi-year residency. They learn so much. And so our job is to not miss the ones that have really serious consequences. And a lot of those other rashes, yes, we're not going to make a perfect diagnosis, but in the end, in the long run, it probably doesn't matter. So let's talk about those life-threatening rashes that you can't miss. That's what we're going to go over for these next 30 minutes. So we're going to talk about toxic shock syndrome, we're going to talk about Stevens-Johnson syndrome, toxic epidermal necrolysis, and some of the bullous diseases, the blistering, the blistering and vesicular diseases, and we're going to talk about necrotizing fasciitis at the end. Although that's not a rash, but it can often present with redness of the skin, etc. So we're going to throw it in there as well. So about 1 out of every 20 patients we see in the ED is going to come in with some kind of dermatologic complaint. So it's a really common problem. And probably the most common things we write on our charts are dermatitis. We don't really know what it is. Some kind of inflammation of the skin in general. I don't know what it is other than that. Urticaria, or some kind of an allergic phenomenon. Bacterial skin infections falls into this category. Fungal infections. These are kind of the common ones we reach for when we're not sure what it is. But how do we spot the life-threatening ones? That's our job, is to make sure those don't slip through our fingers, and nothing like a bad case of a bad dermatology condition to slip through your fingers that can really ruin your day. So when you're asking your questions about your patient who comes in with a chief complaint of a rash, what are the things that really need to be in your history of present illness that will help alert you to the potential for something serious going on? Certainly someone who comes in with a rash and a fever, that raises a red flag for us. Certainly when you have someone who's very young or on the older side, these are all, relative immunosuppressant type things that worry us in lots of other conditions as well, but it's also the same for dermatologic conditions. Someone who looks really sick, hypotensive, yeah, okay, that would raise my antennas for sure. Someone who's immunocompromised, someone who's, on steroids, on some kind of immunocompromising medication or has a condition, that should worry you as well. A rash in that person could be a lot more serious than it appears. Adenopathy, meaning that someone who comes in with a rash, you need to do more of an exam and kind of look for things like adenopathy to give you an idea whether or not there's systemic involvement. Diffuse erythroderma, if they're kind of red all over, that is kind of worrisome, that there's really a systemic inflammation going on. People with petechiae and purpura should worry for you for some kind of bleeding disorder or a vasculitis, again, indicating that it's not just a skin disorder, but it might be something more systemic, and you're just seeing the skin part of it on the outside. Someone who started some kind of recent new drug, and this is an important question to ask because some of the conditions we will look at can be associated with antibiotic use. And for example, they may not be on that antibiotic right now, they may have finished that antibiotic, but asking kind of any new drugs, even ones that you may have finished in the last few weeks, is an important question, really digging into that medication history, including things that are over the counter and not even prescription would be important questions to ask. Arthralgias, again, indicating more systemic involvement, and then any kind of severe localized pain or an extremity that's particularly painful, we have to think more about things like septic joint cellulitis, neck fash, that kind of thing. So those are really kind of important questions to include in your HPI, and it will help you not miss some of these more serious dermatologic conditions. So a good derm history is important. Kind of how did it start? How quickly has it developed? The time course is important. Have they been out of the country or any kind of recent travel? Household exposures as well, other contacts that might have similar rashes. What do they do for a living? What kind of chemicals or other exposures might they have that have to do with their job? And then we talked about medications, and past medical history might also, again, raise some red flags for you and make you kind of a little more concerned than your average rash. The whole idea is to, make sure that you're not missing one of these more serious conditions. So when you're talking about rashes, just in addition to a lot of the other disorders that we deal with, we pride ourselves in the emergency department for speaking the language of our consultants. So as we're describing rashes in our charts, remembering what these terms actually means is worth reviewing. Remembering that a macule is something that has no skin elevation associated with it. That's a macular type rash. A papule is something that's raised. So when we talk about maculopapular, we're talking about a rash that has flat components but also has some raised components as well. If we're using the word vesicle and bulla, they're really the same thing. It has to do with the size of the actual blister that we're looking at. Petechiae and purpura, also the difference between those two things. So remember to use the words appropriately and choose the right words. And if you're not sure between the words, then just describe what you see in plain old language. That's fine too. Describing the size of the dots, what they look like, are they flat, are they raised, is just as fine as using the terms if you're not sure what they all mean. So let's talk first about toxic shock syndrome. Not a common diagnosis, but one, again, we have to be aware of. This is a toxin-mediated problem. It can be from a strep infection or a staph infection. This used to be something we mostly learned about this during the age as tampons kind of came out. And basically, as you have something that's cotton that's in contact with fluid for a while, indwelling in your body, you can get basically overgrowth of bacteria there, and then you get this toxin-mediated problem. That's really true with even when you pack abscesses with something that's of cotton material, like noses, for example. When we pack noses with Rhino Rocket, if it has that kind of tampon associated with it, you have to be worried about toxic shock syndrome in those patients as well. And they often go out with prophylactic antibiotics to make sure that they don't develop this problem. Patients who have surgical wounds, postpartum, any kind of that kind of packing that's sticking around can cause the same problem. What is your patient going to look like? Well, your patient's going to look really sick, so this isn't going to be a subtle thing, but this is where that diffuse erythematous rash comes into play. You see someone that basically looks almost sunburned all over. You have to be worried that something's going on more systemically. So the patient who comes in with acute febrile illness and diffuse desquamating erythroderma is someone who's concerning to you. They look kind of red all over. That should worry you. You may also see in toxic shock syndrome some mucous membrane involvement, and we're going to talk in some of these conditions about not only examining the skin, but making sure you're looking at the conjunctiva and the mucous membranes, looking inside the mouth. That would also involve the vaginal area, anal area. Anywhere where there's mucous membranes is something you also want to examine and comment in your physical exam whether or not you see any mucous membrane involvement or conjunctival involvement. So sunburn type rash plus shock, that is toxic shock syndrome until proven otherwise. To make this diagnosis, there are some specific diagnostic criteria that you could always look up later if you're thinking about it, but basically you need to have a real fever, at least 102, a real fever. They have to have shock, but it's toxic shock, so there's got to be shock as part of it, so hypotension's on the list. And then they have to have this diffuse blanching, meaning if you push on it, it turns white, type of macular, so flat, erythroderma, so a flat red rash that turns white when you push on it, plus a fever, shock, and then they have to have some organ dysfunction, meaning that their creatinine is bumped or their LFTs are bumped or some organ systems that are involved. What is the course of this illness? Well, basically the rash will typically fade within a few days, and then they will have a full thickness desquamation of that skin that's affected, including their hands and feet. So these are typically patients, as with a lot of these dermatologic conditions, that would be best served certainly in an ICU setting, but a burn ICU in particular, that can deal with their fluid needs and their basically desquamated skin needs as well, which puts them at risk for a lot of infections in and of itself. So what are we going to do for these patients? Well, we're going to resuscitate them in our standard ways. We're going to use IV fluids, pressors, ventilatory support should they need it, and we're going to give them antibiotics to cover the strep and staph that may have started this whole thing. Now, this is already toxin mediated, so we're really behind the 8 ball when we get started with these antibiotics, but we're going to give them because we just got to make sure that there's no further progression of the disease. If there's any infected sites, for example, there's packing left in somewhere or some kind of abscess associated with this, we're going to drain those sites as well, and then we're going to give them pretty big gun antibiotics for toxic shock syndrome. Now let's move on to another patient. We have a 20-year-old male. He has had kind of a subjective fever and a little cough going on for a week. He tells you when you ask, okay, well, have you been on any medications? You seen any other, I always ask, have you seen any other doctors for this, any other medical providers for this condition? Yes, he went to a little local clinic somewhere, and he was given a Z-Pak and an IM injection of some kind of antibiotic. He doesn't know what it was, but something, gave him something. And now he's coming in, and now he really does have a fever, and he's got this rash. And so let's look at the rash and see what you think. So here's his back and his chest. You're like, okay, well, looks sort of red, maybe it's macular, you gotta, kind of touch it with gloves on, you gotta kind of see, is it papular, is it macular? We always look at the hands and feet. There are particular lists of things that can affect the hands and feet, so we're gonna look at those feet. Okay, we see it on the soles of his feet. That's worrisome. That's often not typical of most rashes. His hands as well, and it's hard to see, get a lot of detail there, but if you really look closely, those look maybe like almost kind of targetoid, sort of some white component and some red circles as well. So hands and feet, that is worrisome. That is worrisome. And here you look a little closer, see what I'm talking about? You see sort of the red circle with sort of the blanched center or the white center, sort of a targetoid appearance. What could that be? What is our diagnosis? And here's back to the back. It looks like probably it started on the back. If you asked him, he said, yeah, this all kind of started on the back, and now it's kind of coming on my hands and feet. So this is kind of how it's progressing as you see these kind of older lesions on the back. So what is our diagnosis here? And the diagnosis here is Stevens-Johnson syndrome. That's going to be associated with the antibiotic that he was given. So let's talk about what Stevens-Johnson is and its relationship to some other rashes that look similar to Stevens-Johnson. So Erythema multiforme is another thing that can look like this. It can also look that sort of targetoid type lesion, and we'll look at some pictures of that. Then you have Stevens-Johnson syndrome, and you also have toxic epidermal necrolysis. And all of these things are sort of related in that they can look similar, certainly at the beginning, but they have very different etiologies and very different outcomes. So erythema multiforme is sort of one separate thing. And then I want you to think of Stevens-Johnson and toxic epidermal necrolysis kind of in the same category. Those are very, very bad. Erythema multiforme is a pretty benign type of rash. There are major and minor forms of erythema multiforme, and erythema multiforme is basically mostly caused by infectious etiologies. Every once in a while it can be associated with a drug, but more commonly it's caused by some kind of an infection going on. They have the classic target lesion in an erythema multiforme case. We've seen some of those target lesions in our patient as well. They may have some involvement of the mucous membranes, and it usually has a benign clinical course. Now, Stevens-Johnson syndrome and TEN, which are basically kind of a spectrum of the same thing, are mostly caused by drugs. Every once in a while can be caused by infectious etiologies. They will have really more widespread and more purpuric type macules. You saw on that patient's back how on the back it was starting to get dark, almost like purpura. So you'll see some more purpuric type macules. And they will have also mucosal erosions, and they can have what's called Nikolsky sign, and we'll look at a picture of that, but that's basically where when you take your finger and you rub the very epidermal surface, the epidermis is already sloughing off. You can slough off some epidermis, and that's called Nikolsky sign. And this is really serious and has a lot of high morbidity and mortality. So erythema multiforme can look kind of like these targetoid type lesions. You see that sort of red sort of pattern and it kind of clearing in the center, and that is what erythema multiforme looks like. It has sort of the classic target lesion associated with it. There are a lot of causes of erythema multiforme, and no reason to learn this list except just to recognize that there are all kind of things that can cause this type of rash. A lot of the etiologies here are just different types of infections that can kick it off. And one of the most common ones to be aware of is herpes simplex 1 and 2 can cause this erythema multiforme type rash, but a lot of other viruses can cause something like this as well. If you see a patient like this, they look pretty good, they really don't have, the purpura associated with them, they otherwise, obviously look, well, then you're talking about just supportive management to recognize what it is. If there is a drug that you think might be associated with this, to make sure it's off the list, and you can provide them with some analgesia, antihistamines if they have a little bit of itching, and they can follow up with their PMD or dermatologist. This is going to run a pretty benign clinical course. On the other hand, if we're talking about Stevens-Johnson and toxic epidermal necrolysis, these are mostly conditions that are caused by drugs. Usually they've started some kind of new medication recently. The most common offenders are actually anticonvulsants, but probably a lot of other cases of antibiotic use as well, particularly the sulfonamides, Bactrim in particular, which is a very common antibiotic that we use these days. NSAIDs can also do this as well, and there's a whole list of drugs that can cause this type of reaction. Why does this happen? We don't really know exactly what the pathophysiology is behind this particular disorder. We know that the patients that tend to have toxic epidermal necrolysis, which means basically just Stevens-Johnson's times 10, just worse, more skin involvement, can happen in all age groups, but tends to happen in the older adults. And the Stevens-Johnson usually kind of is in the younger adults and kids type of thing. How do we diagnose these two conditions, the ones that are on the more serious side of the spectrum? Well, this is going to look targetoid. We've mentioned that already. It's going to look a little bit more atypical and irregular. They will have more diffuse, especially on the trunk macules. They may actually even have some bullae, and you may find some parts where you can actually slough away that epidermis, which is the Nikolsky sign. They will have mucous membrane involvement, and that's why it's really important to comment on your charts whether or not somebody has mucous membrane involvement. The oral area, the anal area, the genital area, the eyes in particular. Ocular involvement, conjunctivitis, in over 90% of the cases, over 90% of the cases. So when you see somebody who's got that kind of rash and they've got a conjunctivitis along with it, that should really worry you, and you have to go keep looking into these other mucous membrane areas. Depending on how much body surface area is involved, that helps you differentiate between Stevens-Johnson and toxic epidermal necrolysis. So the more surface area of the body that's involved, the more you're talking about a TEN case. But really, they're kind of a spectrum of the same thing. And you see the mortality numbers listed there. So here's a positive Nikolsky sign. You see that this is already kind of desquamating, and if you just use your finger and you kind of push on that skin, it's just going to desquamate away, and that's Nikolsky's sign. These patients, as they progress, as this rash progresses, and it becomes from that sort of targetoid lesion to more of a purpuric type picture, you will see a lot of desquamation, and the mortality is not good. You can see this is a patient in the ICU. As the days progress, these lesions change to a darker color, they start to desquamate, and they need really constant ocular care to basically clear out the desquamation that happens of their conjunctiva as well. So they will have frequent ophthalmology kind of clearing of that ocular area to keep that moving. So mucous membrane involvement with desquamation, including the mouth as well, pretty dramatic type of cases that can happen from just, again, sort of innocent use of antibiotics or a new anticonvulsant. You really have to take a good medication history to get down to the bottom of it. TEN, as we said, is basically the same thing, but more body surface area. And again, these are, obviously if this came into the ER, you wouldn't miss it, but they don't start like this. They start with these sort of targetoid lesions, but this is how they end up looking as it progresses. So here's kind of a little summary slide. That's a money slide to kind of compare Erythema multiforme and the Stevens-Johnson and toxic epidermal necrolysis, basically looking at the body surface area. Does it affect mucous membranes? As I said, you can have some mucous membrane involvement in Erythema multiforme, but we're talking like limited to maybe one site, and it shouldn't be that involved. Versus Stevens-Johnson will have at least 2 mucous membrane sites involved, and usually the conjunctiva as well. In terms of the rash, Erythema multiforme is more commonly on the extremities, and when you see it on the trunk, you have to be a little more concerned about Stevens-Johnson. In terms of the target lesions, it can look they both have sort of targetoid lesions, but Erythema multiforme usually has more kind of typical classic target lesions versus Stevens-Johnson has sort of atypical, a little bit more irregular looking lesions. And Erythema multiforme is more associated with infectious etiologies, and Stevens-Johnson more associated with drugs that have been started. Not perfect, it's not a perfect association. Yes, you can have some infectious etiology contributing to Stevens-Johnson, but kind of if you want to draw some lines for yourself, those are good lines to draw. And then basically, do they look sick? Erythema multiforme person's going to look pretty well. Stevens-Johnson going to start looking pretty sick to you. So these are kind of a summary of what the differences are. Remember, if you see a patient with conjunctivitis and fever and stomatitis, mucous membrane involvement with this kind of rash, be very worried about Stevens-Johnson. Now let's move on to patients who have vesiculobullous rashes, so blistering type conditions. And there's a couple of them to know about. These are usually pretty dramatic when you see them. And there's one that you have to be really worried about and one that you don't have to be so worried about, which is kind of similar to what we just talked about with Erythema multiforme and the Stevens-Johnson type of picture. So the life-threatening one of these is called Pemphigus Vulgaris, and the not life-threatening one of these is called bullous pemphigoid. Now, this always got me confused on tests because they sound so similar. And so really, if you remember the one with the vulgar in it, vulgaris, is the life-threatening one, then that's the one that's the bad one. And the bullous pemphigoid is one that people usually deal with over time, kind of a chronic condition. What are these blistering vesicular conditions? These are mostly autoimmune diseases. It tends to happen in older patients, and these are blisters and erosions on the skin, including the mucous membranes at times as well. So what are these things? How do they happen? Why do people have their skin blister over time? Well, if you read papers about these types of conditions and why this happens, this is the kind of picture you see in one of those papers, which is that it's complicated. You know, there's a lot of different signaling mechanisms and all kinds of cell things going on. All I know is that it's basically, I think of it as sort of an autoimmune condition, and there's a lot of mechanisms going on behind the scenes as to why people develop these kind of blistering type of rashes. Now, Pemphigus vulgaris is a rare one, but it's potentially lethal, which is why we mention it here. A blistering condition, usually in kind of a 40 to 60-year-old type patient. It usually starts in the mouth and is painful. And you know, think about the other things that you might think about if someone came in with painful erosions in their mouth. And you want to keep this one on that list. You might be thinking about herpes. You might be thinking about, you know, other types of viral infections, some kind of stomatitis. But this one has to be on the list as well, Pemphigus vulgaris. It usually happens over weeks, and they can develop these non-itchy, very fragile skin blisters that kind of erupt in different places over their body. These also will be, as I said, they're fragile, so they break very easily, and we get back to that Nikolsky sign, where if you kind of take your thumb and kind of push on one of these blisters, it'll break really easily. They're quite thin-walled, and they're pretty fragile. Patients who have these have erosions in their mouth. They can also have some erosions on their skin as these blisters erupt. So you want to definitely look in the mouth and comment on that in your chart, and then look in other places for these blisters to be happening. This can be associated with other autoimmune diseases, not surprisingly, given the kind of signaling mechanism in the cells that we're talking about. There are some associated triggers. ACE inhibitors are on the list. Some other kind of more rarely used antibiotics are also on the list as well. If you suspect this, you're certainly going to involve a dermatologist, but what are they going to do for this disease? They're going to give the patient steroids to suppress that immune system. They're going to give IV fluids, and these people are coming in, again, to an ICU setting, and if you have a burn ICU available, it's a nice place to put them because they kind of specialize in this type of condition. Mortality rate, ever since we started using steroids in this condition, the mortality rate dropped down from a very high number to more like 10 to 20%, so that's the good news. Now, bullous pemphigoid is also a blistering condition, but this is a chronic blistering condition, also in kind of older adults. It seems to be getting more common for some reason. Nobody's really sure why that is. They tend to have less oral involvement. They can have some, but it's more uncommon to have any involvement in the mouth. And it's the kind of thing where if you ask the patient if you had this before, it kind of waxes and wanes over years, so they may have had something like this before as well. There are a lot of triggers. It can be everything from UV light to they may be getting their radiation therapy for some kind of a cancer, and you have to do a biopsy to diagnose this. And there's a lot of dermatologists, academic dermatologists that specialize in these type of bullous diseases. You're going to call your friendly dermatologist, and these patients are typically going to be treated with steroids if they have sort of an outbreak of this kind of thing. You know, these days with technology like cell phones, you know, it's pretty easy to call a dermatologist and text this kind of information, give them a picture of this. Of course, this raises HIPAA concerns, and we can have a whole discussion about what that means and how to do that securely. But these days with technology, you know, using a picture can tell 1,000 words besides you describing it, but actually saying, hey, can I just send you a picture of this so you can take a look at it, is becoming more and more common of a way for us to communicate with our consultants quickly and for them to get an idea of what you're looking at. Bullous pemphigoid, if you looked at this patient, you see those blisters, but you see that it's kind of more of a chronic appearing thing. The skin doesn't look completely normal. There's evidence that this has probably happened before and gone away, and you see some scarring and some dry skin, so it's not going to look like that the Pemphigus vulgaris that we saw, where it's really acute. Patient's skin doesn't have any evidence of this happening before. This is more of a chronic type of condition. So we're close to being done with this little section. We have one more thing to talk about, which is to talk about necrotizing fasciitis. And I happen to work at a big county place where we see a lot of patients who have a very untreated bad diabetes, but also patients who use IV drugs and skin popping, that kind of thing. We see a lot of neck fash where I work, so I'm very comfortable and always concerned with this diagnosis. It may be more common or more rare where you work as well. But this is a necrotizing soft tissue infection. It's something that you always have to think of when you see a patient with cellulitis. Before you write off cellulitis, you have to at least run kind of neck fash through your mind to make sure you don't miss it. It's a localized type of rash. It's not a diffuse rash. It's a localized, something hurts, you think it's cellulitis. They may have a bullous component. That's one of the features of neck fasciitis. They develop blisters. They may or may not, they may not have blisters, but if you see a blister with cellulitis, you gotta worry about this. And it can happen anywhere. It can happen on the trunk, it can happen in any body part, but it's more common in the lower extremities. It can also happen on the abdominal wall, and when it happens in the perineum and the groin, we call that Fournier's, right? It's really the same thing in terms of a necrotizing type of infection. The thing to know about neck fasciitis is that as soon as you suspect it or you have some evidence that this is on the radar, you need to be calling a surgeon, because the treatment for this, the most effective treatment, is debridement. And the more you can debride and the sooner you can get it off, the better. So we're certainly going to start broad spectrum antibiotics. That's what we can do. But the other thing we can do is suspect it early and call a surgical consultant early in the course of care of this patient. I mean, this one is obviously, you're just like, this is cellulitis. No, I mean, look at these big hemorrhagic blisters. Obviously, I'm more concerned about something beyond cellulitis. But it's the cases that don't look like this that are the more challenging ones. The cases that really look like cellulitis, where you're thinking, could this be neck fasciitis? Now, it can be deceptive, and some other clues that you can look for is if you do a plain x-ray, you might see some gas underneath the skin. That's a possibility. Again, if you don't have it, doesn't mean it's not neck fasciitis, but when you see it, you see any kind of gas under the skin, you gotta worry about one of these necrotizing infections. Some other clues is that if you did some labs, there are some lab markers that go along with neck fasciitis. One is a low sodium. Low sodium, hyponatremia, should trigger you to think about this as well. They also can have an elevated creatinine. Certainly if you sent a C-reactive protein, that would be elevated. Their glucose may be abnormal, and they certainly will have a big white count. Again, none of these are like set in stone, but there are some calculations, some scores. There's a score called the Erythema score that was developed to kind of help you estimate the likelihood of neck fasciitis. It's not a great score, it doesn't work perfectly, but these are the elements that are in that score to help you kind of increase your suspicion for necrotizing fasciitis. They also can have an increased hemoglobin as they have some hemoconcentration. Again, if you're considering it, the role that we play, the thing that we need to do is to call a surgical consultant early. Even if they're going to blow you off and say, I don't think that's what it is, the point is you have to advocate for your patients and know that debridement is really the answer to this disease. So if you're worried about it, to call for help early. So let's summarize this little derm talk in the 30 minutes of derm. We see a lot of rashes. We have to keep our antenna up for the bad ones. We don't want to miss the life-threatening ones. We want to ask some really important questions in our HPI. We want to get into a detailed medication history. We have to know those red flags of derm. Someone who's immunocompromised, the very young, the very old, people who have other like systemic signs, fever, arthralgias, that kind of thing. And we want to think about when we see patients with targetoid type lesions, it could be Erythema multiforme, common, benign, but it could be Stevens-Johnson. So look at those mucous membranes, look at those conjunctiva, document whether or not you see inflammation there. Stomatitis and the rash as well. When we see patients who have diffuse bullous diseases, there are chronic ones like bullous pemphigoid, but Pemphigus Vulgaris is a particularly bad one, life-threatening one. And these are mostly autoimmune mediated. We want to keep our eye out for those as well. And then neck fasciitis is a life-threatening skin condition, needs early recognition, early involvement of a surgical colleague for debridement. And we want to just keep our eyes open for that one as well. And every time we see cellulitis, we always, often consider, for example, DVT in the lower extremities as a possible mimic, but remember neck fasciitis as well. Even if it just looks like cellulitis, at least let it cross your mind and think about it. Thank you very much.